Good morning and welcome to our webinar series at Warner Orthopedics and the Well Theory. I'm Dr. Meredith Warner. Excuse me. I'm founder of both Warner Orthopedics, which is my practice where I'm an orthopedic surgeon in Baton Rouge, Louisiana, and also the Well Theory, which is a line of natural products that are meant to help you be healthier and combat the scourges of modern life, which are namely oxidative stress, chronic inflammation, and lack of micronutrients. That's me, as we discussed. I also teach for LSU Orthopedics. I also teach for East Jefferson Podiatry residency program. And I just have developed over the years a love of all things natural, despite also still writing prescription medicines and performing surgery. I think that the best of both worlds should be combined, and that's what we try to do for you. Today we're going to talk about bone health, which is obviously a topic that is near and dear to my heart as an orthopedic surgeon. So what factors affect bone density? What is the impact of inflammation and oxidative stress on bone? How does muscle and strength play into bone health? I'm sure you've heard that that's important. What is bone's impact on brain health? You may or may not know about that. And then different natural ways to improve bone health. I'm going to just kind of lightly touch on multiple topics and not go too deep into any of them. If there's something that you guys think I should go deep on, we can do another talk later. There's just so many things that play into bone health. It's kind of hard to, really it could be a college level or a medical school level course, not just a simple webinar. So I'm just gonna light brush strokes here. This image at the bottom is showing a particular imaging technology that we have now. Starting from the left, going to the right, just showing the loss of mineralization of a vertebral body over time. And that's when you start getting the little compression fractures and start hunching down with kyphosis. The top picture shows you all the different types of bones. So there's long bones, which is, long bones. So arm bones, thigh bones, shin bones. Flat bones like your shoulder blade and your sternum. Irregularly shaped bones like the vertebral body, which is imaged beneath that. And then short little tiny bones like the capitate and the talus. Interestingly, one of the foot bones, the cuneiform, used to be one of the methods of money exchange. So cuneiforms, hopefully from animals, were used as sort of a form of currency, if I'm recalling correctly. And then sesamoid bones, which are little bones that are found embedded inside of tendons. And what they do is they change the relative force vectors and make certain muscles more efficient and stronger. So what matters in bone is how strong it is, but also how flexible it is, which kind of makes sense because that's what matters in human health. You got to be strong and flexible. Bone density is related to the amount of mineral deposited onto the collagenous structure. Okay, so there's collagen, which is a protein. There's an extracellular matrix all around the collagen that it's embedded in, sort of like the jello it lives in. And then that gets mineralized, and then that creates bone density. So the mass of mineral per volume of bone, okay, and it's generally thought of in grams per square centimeters. High density is theoretically thought to be good. Low density bone mineral density is thought to be bad or osteoporotic. There are some exceptions, of course, to all of these rules. This diagram on the right is something that we're always tested on in orthopedic surgery when we're coming up through the years, the stress strain curve, and this shows you materials and where they fail. So materials should be able to elastically deform with a certain amount of stress applied to them, and what that means is like it'll change shape, but it can go back to its original shape once the stress is removed. But if you hit the plastic deformation part of the curve, then the material has been changed so much that it can never go back to its original structure and it's forever altered. And typically this means that it's broken or it failed. So when your bone hits the plastic region, it's going to break. When your Achilles tendon hits the plastic region, it's going to rupture. Ideally, most of the life stresses would be in that elastic stress strain region that would allow it to go back to its normal shape. And your bone mineral density plays into this. So this is depicting a vertebral compression fracture. You can see it's wedged. So the vertebral bodies, think of them like cylinders with some processes off the back that protect the cord, the spinal cord. The cylinder of bone, they sit segmentally on top of each other with discs between. What happens with a vertebral compression fracture is the ability of the bone to withstand axial compression force is actually less than the ability of the disc to withstand that. And the bone will actually crunch and compress. And because your center of gravity tends to be forward of the spinal column, that's why you get wedge compressions. So it's like you're just going and compressing the front. And of course, what does that do? Well, normally you don't ever get a vertebral compression fracture, which is typically in the thoracic spine or the spine around your rib cage. Normally we would never fix them. Sometimes you can inject cement in them and try to blow them up. That has its pros and cons, and some people like that, some people don't. Sometimes it works, sometimes it doesn't. So generally, if you get a vertebral wedge compression fracture, it effectively is going to change the overall biomechanics of the spinal column, and you're forever going to be fighting this minor angulation towards the front. So like when I have patients that come with vertebral compression fractures, one of my primary ways to treat it is to really work on the posterior backline muscles to sort of really fight that tendency to wedge more and more and more and more. But this is what we want to avoid. That's the whole point of this talk is bone health, to avoid getting things like vertebral compression fractures as we get older. The factors that affect bone mineral density, we think so far, age, whether you're male or female, genetics, how active you are, what are you eating or what's your diet. Hormones play a large role, as you may or may not know. Lifestyle factors, medical conditions, and even some medicines matter. So some prescription medicines that you're put on can sometimes change your bone mineral density, and you may not even be aware of that. So age and gender are pretty much immutable, or we generally can't change it. So you are your age and you are male or female, generally speaking. Generally, the older you are, the worse your bone mineral density is thought to be. And females tend to have worse bone mineral density, although I think around age 80, all things become equal. The density gets the best, or you get the densest amount of bone during childhood and early adulthood, and you peak at 30. So most people have built the biggest amount of bone or the most density in their bone by the age of 30. And that's all you have to work with going forward as a general rule. So menopause in women is one of the reasons that women have worse bone, generally speaking, because the estrogen plays such a protective role for bone mineral density and bone quality that when your estrogen levels change, usually get decreased with menopause. That is one of the reasons that we tend to lose bone mass a little bit more quickly than men do. This image on the bottom, just to show you, is a vertebroplasty with the spinal fusion around it. So that white irregular blob between the screws and the bar there on the spinal canal, that is when you go in with radiologic control. So you do it under direct imaging and put a needle in and literally inject cement under pressure to try to unwedge that vertebral body. And then in this case, this person had a fusion around it. Obviously you want to avoid that, like prevention is the key, and that's what this talk is all about. So genetics, relatively minor role we think, and a lot of what we think of as genetics in medicine is really just that everybody grew up in the same house, in the same community, with the same traditions, the same diets, the same lifestyles, the same level of pollution, toxins around them, the same stress levels, which of course all plays into things. So a lot of what we think of as nature is really just nurture. But there are some genes, and they're looking for more, obviously, and now with AI and big, huge, full human data sets of genetics, we're going to be able to find more and more. And of course, white people have the highest risk of having poor bone quality. So if you're a white female and you're thin, you're in the highest risk group for having bad bone, FYI. But there are a lot of other benefits to being thin, so I'm not disparaging that. And we're going to talk about how to make your bone stronger. Physical activity is probably your number one weapon and the most effective tool that we have, including all the pharmaceuticals and everything else I'm going to talk about today. Resistance exercise is your number one weapon against terrible bone. So the stronger you are, the better your bone is going to be. The more weights you lift, the better your bones are going to be. The more sedentary you are, the worse your bone's going to be, and your body's just going to keep leaching out calcium and just assume it's not necessary. And I'll explain how that works a little bit later. So diet and bone health. As we all know, you are what you eat, and I think that's becoming more and more abundantly clear and factual. So of course in medicine, none of us are taught nutrition. You know that 13% of medical schools teach nutrition. I've talked about this ad nauseum. Anything you hear me talk about with nutrition, I have taught myself with extensive research and learning. No one in medical school taught me this, and certainly no one in orthopedic residency taught me this. Most surgeons are not taught any of this. I think hopefully that's changing now, but it is still rare. So if you want to know about nutrition and health, you're gonna have to find somebody that's extremely interested in it, like I am, or you're gonna have to teach yourself, unfortunately. But you are what you eat, and that plays into bone. The key nutrients are what you would think they are: calcium, vitamin D, but also protein, which a lot of people don't really think about, but bone is really just protein. It's just mineralized protein, but it's fundamentally just collagen. It's type 1 collagen. That's all it is. And then it gets mineralized. So protein, again, and I've harped on this, none of us eat enough protein. Protein is important if you want to have strong bones. So protein, lifting weights, calcium, vitamin D, magnesium, phosphorus, a variety of minerals all play into good bone health. And we're going to talk about other micronutrients. So detrimental foods, we know what the good foods are, and we'll talk a little bit more about those, but the bad foods, a lot of people think foods high in oxalates are not really that great for bone, and also high in oxalate foods can cause calcium to precipitate in urine and give you calcium or renal stones, right? So a lot of people that are at risk of kidney stones need to avoid oxalates. So these foods like spinach, which you're traditionally told has calcium and helps make your bones strong, that's true, but also has a lot of oxalates, so maybe you want to avoid that particular green leafy vegetable. The low oxalate greens I put here for your reference: arugula, which is my favorite, 0 oxalates; romaine, 0 oxalates; kale, only 2 milligrams; endive, which are those kind of like little boat shells, and they're really cute and you can put dips on them. That is 0 oxalates. Bok choy, just 1 milligram, and cabbage, none. So coleslaw all day long, right? But the high in oxalate foods are listed here, and actually almonds are high in oxalate, which I didn't really realize. Almonds have a lot of other benefits, but just think about that. High sodium diets tend to increase calcium excretion. The kidney pumps them out together. Caffeine tends to decrease your intestinal absorption of calcium. That's why probably the old wives' tale of calcium stunts your growth. Potentially, who knows where that came from. Excessive alcohol intake also interferes with calcium absorption in the intestines. So all of this is going back to gut biome, microbiome, and gut health, of course, and also can affect your hormone levels. And then the phytates and oxalates we find in different foods can also reduce calcium absorption, and also the oxalates can increase calcium precipitation in stone form in the urinary system. So these are foods you want to avoid. High in sodium, you want to avoid excessive caffeine, excessive alcohol intake, not too many oxalates. And then also these, which again, we harp on this in almost every talk: ultra-processed foods, horrible for bone. Hydrogenated oils, partially hydrogenated oils. All of these destroy your vitamin K levels, damage bone, increase oxidative stress, which damage bone, increase inflammation, which damages bone, damages your gut biome, decreases intestinal absorption of good nutrients. Any added sugars, what does that do? Insulin resistance. And anytime you have added sugars in your serum, your body is going to try to regulate that, and you're going to try to urinate it out. And then what's going to go with it? Calcium. So you're going to have more insulin resistance and also be urinating out calcium. What does that mean? Bad bone. Phosphoric acid, I put the back of a Coca-Cola can here. And this is regular red Coke. So carbonated water, high fructose corn syrup, caramel color, who knows what they use to color it, which chemical, phosphoric acid, natural flavors, and caffeine, okay? Phosphoric acid is thought to leach calcium from bone. This is why people tell you to try to avoid too many dark sodas. Apparently, the light sodas don't seem to have this problem. But anyway, no one should be drinking high fructose corn syrup, so none of you are drinking this. I just put it there as an example. Foods that are good for bone health. I mean, obviously, dairy, A lot of people don't like dairy. I love dairy. Animal fats, I think, are healthy, natural, normal. And dairy-based saturated fats can be cardioprotective, believe it or not, versus other types of saturated fats found in the natural world. Dairy is just chock full of protein, chock full of calcium, vitamin D, etc. So yes, all the dairy, milk, etc. The green leafy vegetables we talked about. But something you might not think about is broccoli. Broccoli is not only high in calcium, but it's also high in vitamin C, which brings me to oranges and things like that. The more vitamin C you can get into your system, the better. Why? Because the superstructure of collagen is a triple helix. So it's 3 fibrils of strung together amino acids that twist around each other. Why do they twist around each other? Because each protein has a certain structure, a certain molecular structure, and the valence electrons on the outside cause the protein to shape in certain ways. So that's why all collagen is a triple helix. But what connects the braids together are cross-links. And the fundamental vitamin that allows good cross-linking of your bone collagen and also your cartilage and your tendons and your ligaments is vitamin C. So this is why Mutiny on the Bounty, that old book, if anybody out there read it, it was one of my favorites, when they had to go find the breadfruit, the Navy did, the British Navy, the reason they needed it was to prevent scurvy in the naval sailors. And what is scurvy? Scurvy is a deficiency of vitamin C, in which case you just start bleeding out everywhere. Why? Because none of your tissues can hold together. So anywhere there's a mucous membrane or an orifice, people would just start bleeding, teeth would fall out, et cetera, et cetera. And that was from a lack of vitamin C because the collagen could not cross-link. So our RDA level of vitamin C set by the federal government is really just to prevent scurvy, not for optimal health. Just remember that about RDAs. Bone broth I want to put up here because that is my preferred way to get collagen. There's a big boom in the collagen world selling collagen powders, collagen pills, collagen drinks, et cetera, et cetera. But to me, homemade bone broth from a grass-fed, grass-finished animal that is organic, or which ate organic foods as it was raised and grown up, I think is the best way to get the fundamental amino acids necessary for you to make good bone, good cartilage, good skin, any good connective tissue. So bone broth is another thing that you may not really think about off the top of your head as good for your bone, but it really is. It's bone broth. So what is bone? It's a structural element. That's it. It's a structural protein at the end of the day. Bone is designed in such a way that allows for both compression and tension. So you can apply compressive loads to it, and you can also pull on it and bend it, and it is able to withstand all of those different force applications. So it basically allows us to maintain our position in space in a world that has a force of gravity. So without it, we would just be a puddle on the ground, right? So we have a superstructure that allows us to resist gravity, and it also is an attachment point for muscles, ligaments, tendons, etc., and it also protects organs. So everywhere there's an important organ, like a brain, there's a bone around it. Made primarily from type 1 collagen. There are a number of different collagens, but type 1 is 90% of what bone is, which is a structural protein of a triple helix of collagen. And then the jello that is around all of the collagen is the extracellular matrix. Nobody really talks about the extracellular matrix of tissues too much, but it's probably the most fundamental part of any tissue. And the bone extracellular matrix is no exception. And that is what allows bone to become mineralized and kind of connect everything together and make it harder. So you have cortical and cancellous bone. So think of a chicken bone. There's the kind of hard, thick, white outer ring, and then the inside's kind of spongy. Well, the inside is cancellous or spongy bone. The outside is cortical bone. And they each serve different purposes. Then, of course, the extracellular matrix, and then there's different levels of skin or fiber around these things, periosteum, endosteum. And going in and out of bone are nutrient blood vessels, just like any other tissue. And then there's pathways of blood vessels within the systems of the bone, and each subsegment of bone in the cortical bone is called a Haversian system or Haversian canal. And that is lamellar bone. It's called lamellar because it's a bunch of lamellae that line up together and sort of stack sheets. And then each bone has, long bones connect to each other with a joint, which is, your knee joint, your elbow joint, etc. And then every bone has either tension or compression or both being applied to it at all times. And we're able to withstand these forces because bone has the capacity to sense stress and respond to it with self-repair. And bone is plastic and it can change. So the more you load bone, the more it's going to build up that area of bone and vice versa. So cortical bone is also known as compact bone or not spongy bone. It is dense and it is the outer layer of bone. This is what provides your strength and protection, and it has those tightly packed Haversian systems. So it's essentially cylindrical structure made up of concentric, meaning parallel in a cylinder way, layers of calcified matrix. That's it. And then you have all of the feeding nutrients. And that is what allows us to fight gravity and stay upright, because this is really good at resisting axial load. And then the spongy bone, we also call it trabecular bone. That is inside the bone, particularly long bones and flat bones. It is lattice-like, it's porous, and there's certain pore sizes in spongy bone that allow for movement of capillaries, movement of red blood cells, movement of nutrition to allow bone to grow. And a lot of our orthopedic devices and implants that we put into people, if we're trying to get the interface of the implant, like a total knee replacement, to integrate with the bone that it's put on, so your bone, you want the undersurface of the metal of the implant is usually what's called trabeculated metal, and they make it so that the pore sizes match the pore sizes of your spongy bone. And so all of those things can kind of go through the metal pores and the bone pores and sort of meld it all together. So the pore size is very, very important. What happens in osteoporosis is these things get bigger and bigger and wider, less dense and less structurally sound. So what having the spongy bone does for us is it still allows the bone to maintain its strength because of the compact bone on the outside, but it reduces weight and gives you a certain amount of flexibility. So unless you have the ability to withstand and bend, you will break all the time, right? This is why wooden buildings handle earthquakes better than cement buildings, because the cement is too dense, it's too brittle, it can't handle shaking. Wood is the opposite of that. So bone has to be perfectly in the middle. You want some flexibility or you will always break, but you don't want it to be so wimpy that it's bending all the time and is not able to withstand the forces of life. And the human system is very elegant and has built up a beautiful feedback system to manage this. So bone marrow, which we just briefly touch on, that is in the spongy bone. There's red bone marrow, yellow bone marrow. Red bone marrow is what makes blood cells in a hematopoietic system. So anything that starts with stem cells in the blood system begins in the bone marrow. So that's not just red blood cells, but also white blood cells and certain stem cells for other tissues. And then the yellow bone marrow is kind of yet another place in our body to store fat. And as we get older, you get more and more yellow marrow and less red marrow. So your bone becomes less productive and more of an energy depot. That is particularly true if you're insulin resistant or if you give too much sugar. Again, another reason too much sugar is bad for bone. And this picture shows you both. A bone marrow in this soup with yellow marrow, and then the one on the bottom looks like it has a little bit more red marrow. Okay, the periosteum. We call it the skin of the bone in orthopedics. It's a very thin fibrous membrane that covers the outer coating of every bone in the body. And this harbors stem cells, it harbors osteoblasts and osteoclasts, it harbors blood vessels. It's sort of like, it's kind of gives the lifeblood to bone, if you will. So it has your blood vessels, your nerves, your cells important for bone growth and repair, and it's really, really thin, just a few cells, and it's just on the outside. Anytime we do surgery on a bone, we try, or at least I try, to preserve the periosteum and not completely rip it off of the bone because it is so important to the biology of the bone. The endosteum, endo, anytime you hear endo in medicine, it's inside, peri's kind of around. So the endosteum is aligning the inner surface of the bones and is in the medullary cavity. And this is important in remodeling. Remember I told you bone can self-repair, so you're self-repairing right now, so am I, all day long, but mostly at night, and we'll talk about that. Your body is going to sense different loads and stress, and it's gonna notice abnormal collagen structures and anything that's not quite right, and it's gonna remodel the bone. which means it's going to destroy and pull out the bad bone, and it's going to replace it with good new bone. And I'm going to tell you how that happens. So that happens by virtue of the osteoblasts, the osteoclasts, and the osteocytes. Osteoblasts are cells that build bone, and they secrete a protein called osteocalcin, which communicates with the brain, come to find out. Osteocytes are mature bone cells found within that extracellular matrix we talked about, and these are bone cells. So an osteocyte, just like cartilage is a chondrocyte, okay? Skin is keratinocyte. Cyte just means cell, osteos bone. So these are the maintenance guys. So they're just sitting there making sure the bone's happy, it's nutritious, it's taking signals in, putting signals out. And occasionally bone will be removed to harbor these. And then there's the osteoclasts, which you could think of them sort of as a bad guy, but they're needed. So these are the cells that go in and break down old and useless bone, chew it up, spit out the parts for recycling, but behind them should be coming the osteoblasts. And they work in a very, very concerted way together. It's a very well-designed system that if it gets disrupted, then you get conditions like osteoporosis, which we're going to talk about. But you want both. You don't want your body to keep old, useless, messed up bone that's been damaged, worn down, or has abnormal proteins. You want your body to have the ability to go in and repair that and recycle it. So the composition of bone, just briefly, you've got your matrix, organic and inorganic. Organic is going to be your collagen fibers, your cells, your different little proteins that are important, blood vessels, things like that. And then in the inorganic matrix, this is when you get mineralized. So calcium phosphate crystals, hydroxyapatite come in and give hardness, just like coral. So bone is very much like sea coral. And a lot of times some of our synthetic bone grafts actually are synthetic sea coral type structures, hydroxyapatite. That is what makes your bone dense. That is your bone mineral density, which a lack of that is your osteoporosis, which we don't want. So having both an organic and an inorganic matrix in a perfect ratio gives you strength and a lightweight superstructure that lets your body function in a gravitational field on the planet Earth. Type 1 collagen, we talked about it. So you have certain amino acids, and in type 1 collagen, glycine is the third amino acid all the time. That is what gives it the bending helix structure. And then the other two vary, typically proline and hydroxyproline. But glycine, which we have a single supplement amino acid, glycine, is hugely important for connective tissue because of this, because it is in every third position in the amino acid string that becomes collagen. It's a triple helix, we talked about that, and then the crosslinks are formed with vitamin C as a cofactor to allow these three collagen molecules to connect together, and then all of those build up and you get a collagen bundle, and then it gets mineralized and you get bone. Hormones play into this, changing you from normal, nice, spongy bone with the perfect trabecular superstructure to widen, bigger interstices and thinner cancellous outer membrane. Low testosterone levels can lead to osteoporosis. This is mainly an issue with some men, but this can affect women later on in life. Low estrogen levels, hugely a problem for women. This is one of the reasons menopause is so detrimental to bone health. And then hyperthyroid or high levels of T4 can cause osteoporosis, and then too much parathyroid hormone. And I'm sure I'm leaving off hundreds of different hormones that play into it. But these are ones that you think about. We're always getting our thyroid panel checked. You may or may not get your parathyroid checked. I check it for people. And then testosterone and estrogen. You need to have the right levels through life if you want to maintain healthy anything, but also bone. Okay, lifestyle. How does this play into it? Poor nutrition, common problem, totally preventable. We've already talked about that. No micronutrients, common problem, totally preventable. I'm a big fan of supplementation because it's so hard to get the appropriate nutrients from an American diet. Smoking, no one should ever do it, period, end of story, totally causal osteoporosis. Inactivity or sedentary life, or a life that has no overload. In other words, no progressive overload, or you are never encountering the need to lift something heavy. That will lead to osteoporosis. And then, of course, we already talked about excessive alcohol intake and other issues that change the absorption, caffeine, salt, things like that. But that's in your nutrition category. So get your lifestyle right. Number one thing you can do to help everything is not smoke. So if that's you, good. You're like 80% there. Avoid ultra processed foods. You're about 90% there. So everything else you're talking about is just to get you optimized. Medical conditions that matter: hyperthyroid, hyperparathyroid, celiac disease, kidney disease, and inflammatory arthritis. So the parathyroid helps the thyroid kind of turn on and off calcitonin, which then goes to affect bone density by virtue of calcium absorption. And if you are hyperthyroid, you are going to be in a condition where your body is stimulating the osteoclasts a bit much and not preserving bone. So it's like a hormonal imbalance. This is with extreme hyperparathyroid, obviously, but some people have started to look into subclinical hyperparathyroid. That is when there's effectively too much T4, but the thyroid stimulating hormone hasn't changed. So it's not bad enough for the pituitary gland in the brain to change the TSH levels. This is why some physicians, rather than only checking the TSH, will also check a free T3 and a free T4. I try to do that, and I'll also check parathyroid levels and vitamin D levels, because there are some subtle abnormalities that can happen, but just know that thyroid affects everything, but it does affect bone dramatically. And then celiac disease changes absorption of calcium, of course. So that's kind of a problem. So people with celiac, if you have true celiac disease, are prone to getting osteoporosis, and that should be remembered. And briefly, what does that mean? It's just a malabsorption problem because your intestine becomes damaged because of these antibodies to the celiac, or a component of wheat proteins. So healthy intestine have what are called villi, which are like these strings that stick up that have all the receptors and pores and stuff for absorption, and also the protective elements to keep bad things out. Well, with celiac, over time, they become stunted and short, and they just don't function correctly. And so there's malabsorption of calcium and vitamin D, which of course we know D is extremely important. And then you get weakly mineralized bones. Also, chronic inflammation happens with any intestinal problem, and that includes autoimmune issues. So elevated levels of tumor necrosis factor alpha, which is a pro-inflammatory cytokine, can damage bone. Elevated levels of IL-1 and IL-6, that's interleukin. These are cytokines or proteins in the inflammatory system. And then all of these act to stimulate osteoclasts, which go in, chew up the bone, but they're not balanced by the osteoblasts. So anytime you have chronic inflammation, you are changing that fine balance between the osteoclasts and the osteoblasts in favor of osteoclasts. That's why chronic inflammation, which is bad for you in every facet of life, is also bad for bone. And then we've talked about early menopause and things like that. Lack of estrogen is a big problem. So kidney disease, I see this all the time. I treat a lot of diabetic patients, and a lot of them have end-stage renal disease, and some are even on dialysis. And those patients, whenever they have a bony problem, are the hardest to treat because their bone will just not heal, because their calcium, phosphorus, vitamin D balance is just so destroyed because their calcium cannot regulate the excretion and retention of certain nutrients. So your calcium and phosphorus balance gets messed up. You don't excrete enough phosphorus, and you cannot activate vitamin D into calcitriol. So part of the vitamin D cascade, we all know that when sunlight hits your skin, it helps form normal active vitamin D, but the precursor to that is made in the kidney. So if your kidney's dysfunctional, it doesn't even matter how much you get out in the sun or what levels of D you're taking, unless you're taking the activated form, because your kidney is not able to turn the inactive precursor into the pro molecule that can be activated. So chronic kidney disease, end stage or not, so remember there's level 1, 2, 3, 4. Chronic kidney disease really changes a balance of formation and resorption because the body is unable to maintain the proper levels of the minerals and the micronutrients needed, because the recycling system of the kidney is not functioning properly. And so you get not just disrupted mineralization in your bone, but you will start mineralizing in random spots for no apparent reason. So people will get, skin will get calcium deposits, muscle will, different random connective tissues, and also blood vessels, and they'll get bigger, thicker, worse atherosclerotic plaquing. So kidney disease is a big problem. Medications. You probably know this, but you may not. Long-term steroid use is a very well-known risk factor for osteoporosis. Sadly, I've seen a lot of patients that just keep going back and getting pain injection after pain injection after pain injection for whatever reason, which are always steroids, and then wonder why they get osteoporosis earlier than they should. So, you know, anytime you go to the doctor and they offer you steroids, just never take it lightly. Once in a while, I think it's reasonable and okay, but these repeated chronic treatments is definitely going to impact bone mass. And actually, long-term corticosteroid use will also cause a condition called avascular necrosis, which is literally dead bone. So I would avoid chronic frequent steroid use unless you absolutely need it as a life-saving drug for some other condition. Anti-seizure medications like phenytoin, things like that, these actually cause osteoporosis. Thyroid replacement drugs, why? Because if you take too much levothyroxine, you can effectively put yourself into a hyperthyroid state, and we already told you that that causes osteoporosis. Immunosuppressants, and then warfarin actually also can cause osteoporosis. That's Coumadin. So long-term use of Coumadin can actually be bone damaging. And then I didn't put on the list here, but probably should have, long-term use of acid blockers like Protonix has also been shown to increase fracture risk and damage bone mass. So if you're on like Protonix and things like that, you may want to try to figure out a way to manage your GERD otherwise, because that can cause fracture with long-term use. So warfarin inhibits vitamin K dependent proteins. So it actually prevents what's called the carboxylation, which is just a molecular change in the structure of that protein osteocalcin we talked about that the bone emits, and also some matrix proteins. So vitamin K is essential for bony mineralization. And if you inhibit the normal function of vitamin K like warfarin does, it impairs the mineralization of bone. So you're effectively stopping the function of vitamin K, which is associated with blood clotting, which is why people take warfarin, but you're also affecting how vitamin K helps bone. And it decreases the activity of the osteoblasts, or the bone forming cells, and it will increase the number of osteoclasts. So warfarin, meant to prevent blood clots for people, actually damages their bone with long-term use. And other anticoagulants do not do this, but I have a lot of patients where the insurance companies will only cover warfarin and will not allow them to have better, safer meds for long-term use. Okay, osteosarcopenia, it's probably my new favorite word of the decade. Nobody should get osteosarcopenia. So what is that? Osteoporosis plus sarcopenia. What is sarcopenia? Lack of muscle. So weak bone and lack of muscle, not a good combination to be a human on the planet Earth. There is a very strong interplay between muscle and bone. We talked about this. Mechanical loading dramatically affects everything in your body. Mechanically loading bone makes it better. Not mechanically loading bone makes it worse. The osteocytes, you already know what that is. Those are the cells just hanging out in the bone, maintaining things, actually can sense mechanical load. And then they upregulate or downregulate a molecule called sclerostin. And then they also have other metabolic influences like bringing in nutrition, getting rid of nutrition, bringing in inflammatory cells to clean up debris for bad bone, and making sure the inflammation goes away when it's not necessary. Sarcopenia, if you have less muscle mass, which we are all gonna eventually have less muscle mass unless we fight it off with weightlifting as we get older. If you have reduced muscle force as you get older, you're gonna get weaker bone. Well, then it becomes a self-feeding cycle. Weaker bone causes more pain when you're trying to lift weights and have load. You get more connective tissue aching because you have lack of soft tissue tolerance. And then you don't want to lift as much, so your muscle gets weaker and your bone gets weaker, and so on and so forth and so on and so forth. So if you want to avoid this cascading toilet bowl of osteosarcopenia, the only way to fight back is to lift something heavy. What is sclerostin, you may be wondering? This is a protein that actually inhibits bone formation. There's a certain genetic pathway that my orthopedic residents are tested on, the WNT signaling pathway. And sclerostin inhibits that. So WNT is pro-bone, sclerostin is anti-bone. Sclerostin stops osteoblasts from turning into osteocytes. So what does that mean? That doesn't sound so bad, right? But what that means is it's changing the overall balance between the osteoblasts, osteoclasts, and the osteocytes. What sclerostin is really doing is it's like a regulator. It's making sure that each bone is appropriate to its function. So each bone has the right shape, each bone has the right size, and each bone has the right density. So think of it this way. You wouldn't want your finger bone to have the size and density of your forearm bones, right? You don't want your foot bones to be like your femur bone. All of this is regulated by sclerostin in terms of bone remodeling and growth from childhood on. Parathyroid hormone inhibits sclerostin. So if you're inhibiting something that inhibits, that's a double negative, right? So if sclerostin inhibits the bone-forming pathway WNT, and you inhibit sclerostin, then you're actually making more bone signaling pathway. That's how parathyroid helps to build bone. And then loading reduces sclerostin. So again, a double negative. Mechanical load inhibits sclerostin, which means you get more of the WNT signaling pathway, which means you get better bone. Estrogen suppresses sclerostin. So we're noting a common theme. Anything that diminishes the level of sclerostin appropriately will make your bone better. And steroids increase sclerostin. This is why corticosteroids are terrible for bone. So sclerostin is something we've learned about in the past decade or so in medicine, and there are certain drugs targeting it I'll talk about. This is actually bone, the superstructure of a starfish, by the way, at electron micrograph level, just to show you how similar all these things in nature are. So starfish, coral, human skeletal bone, very similar in structure. So resistance exercise and bone health. This is just showing you muscle going down in level to the smallest level, which is actin and myosin. Again, just protein. So if you get a fracture, your risk of sarcopenia goes up. Why? Because you're immobilized, you're not using something, and your activity levels change. So not only do you have a weak broken bone, but now you're weakening the muscle around it from immobilization and disuse. I'm a big fan of early motion and early weight bearing after any injury or any surgery. So as soon as it is safe to do so, I do it. There's a lot of literature now coming out showing that even after ankle fracture surgery, weight bearing immediately is totally safe, does not make outcomes worse, and in fact improves functional recovery. And this is why you don't want to get this immobilization and disuse and sarcopenia from injury and fracture. And then so fracture increases your risk of sarcopenia, and then if you become sarcopenic, you have an increased risk of fracture. So again, a self-feeding, bad, negative doom loop. Falls are much more likely to result in fragility fractures in weaker people or people with less muscle mass. And these people have less strength, less balance, less function, less performance, less ability to withstand the tension and compression applied just from normal movement and load in a gravitational field. Sarcopenia is highly associated with malnutrition. One of the reasons older people tend to lose muscle mass, not only do we just stop becoming active in our 40s because everybody's just too busy working, but what happens over time is you eat less and less protein. It's really hard to eat enough protein on a daily basis. We've talked about this. Older people tend to eat even less protein, and then again, it becomes another self-feeding doom cycle. So you really just have to actively fight back. You've got to eat enough protein and do enough activity that involves resistance or load or weights to maintain muscle mass, to prevent fractures. And then if you get a fracture, the sooner you get back on the horse, the better. So exercise is osteogenic, and the load applied must exceed your normal daily load. What do I mean? If your normal activity is to wake up, make breakfast, watch TV, maybe go for a little walk, maybe go shopping, go play with the grandkids, eat dinner, watch the news and go to bed. If that's your daily activity and that's all you ever do, you're never going to get stronger and build muscle. You have to impart progressive overload at some point. The load applied must exceed your normal daily activity, or you will over time lose muscle. We lose 1 to 3% a year without challenging our muscles, meaning progressive resistance. And this is because of the mechanical stimulation of the osteoblasts to build bone and of the sarcomere or muscle tissue to build muscle. Bone responds to a known rule in nature called Wolff's Law. I think it was German, he may have been English, surgeon described this, Dr. Wolff. Bone adapts to the loads placed upon it, just like anything in life. You know, you get used to what you get used to. So as muscle contraction exerts a mechanical force on the bone's going to say, I notice I'm being loaded more. There's more compression on me. I should probably deposit more mineral and create more lamellar structures to withstand this load. If you don't do that, the bone's not going to grow and get better. This is why weightlifting is the best way to fight osteoporosis, because you can actually create bone. Most of our medications only hold you where you are. This will naturally, with no side effects, create bone for you. So I'm a huge fan of strength, and I think the stronger you can get, the better everything is in life. So you're going to have less sarcopenia and better bone. And again, remember, mechanical load, the osteocytes sense this and they inhibit sclerostin, which means there's more WNT signaling and more bone formation. And that's by virtue of Wolff's Law. So the laws of loading, Wolff's Law, Davis's Law, same thing that happens in bone happens in soft tissue too. So like if you continually apply stress to an Achilles tendon with running, it's going to get used to that, and it's going to alter the microstructure and the tensile architecture of the collagen to withstand the chronic stress on the tendon. And it's going to adapt and become better at that. Same thing with bone. All of this, same thing with the brain. The more you use it, the more neuroplastic connections happen, et cetera, et cetera. So the magnitude of strain on the bone has to exceed the threshold required for remodeling. Again, if you're just doing your normal daily stuff, your bone's never going to get stronger. You have to load it. You have to inhibit that sclerostin, and you have to get Wolff's Law engaged. And what will happen is the cross section will increase, and the density of the bone will increase as you progressively overload it.
Do you see hyperparathyroidism in your practice?
The question is, do I see hyperparathyroidism in my practice? Yes. The number one reason I see it is vitamin D deficiency. So it's a response to that. But yes, we see it. Normally, if I see it, it's usually from a micronutrient deficiency, and so we treat that, and people get better. Okay, resistance exercise, a little bit more. Maintains or increases bone mineral density in postmenopausal women. This is just a scientific statement, but the important part of that is or increases. So it's not just going to maintain it, it's actually going to make your bone better and stronger. Really good for cortical bone. Remember, that's the lamellar bone surrounding the spongy bone. Site-specific effects. What does that mean? If you just do curls, you're probably not going to increase your hip bone density. So the important thing to remember for when you do start to engage in weightlifting, which I encourage you to do so, is full body, multiple joint, full range of motion activities that stress all of the important bones that you need to exist on the planet Earth. So you really want to target larger muscle groups and bigger joints, hips, spine, because the one thing you don't want to ever have is a hip fracture or a vertebral compression fracture. So what's the minimum amount of resistance exercise? I get asked this all the time. It's really hard to answer this. I would say the minimum amount is a little bit more than what you normally do. That's the minimum amount. The World Health Organization says 8 to 12 reps maximum, 2 or more days a week. That's a little bit of sort of like a hypertrophy or an endurance routine rather than strength. I prefer the 3 to 5 plan, which is focused more on strength building or increasing the actual mechanical load on your muscle and your bone. So that's 3 days a week, 3 reps of any particular large muscle group exercise, 3 exercises and 3-minute rest between the set, and 3 sets. The important thing is you have to be at 70 to 80% of your 1 rep maximum. So let's say you're doing a deadlift and you know you can deadlift once 100 pounds. And that would be it. You're done, you're fatigued, you can't do any more that day. You would want to go to 70% of that, so 70 pounds, and do it 3 times, rest 3 minutes, 3 times, rest 3 minutes, 3 times, rest 3 minutes. So that's how you build strength. And you only do that 3 days a week. Why? Because in between the mechanical sensation from Wolff and Davis's law are going to turn on the genetic components that force the proteins to build. So you have to have that time of recovery whereby the protein in the bone structure actually happens. If you continually are stressing it, it can never really do that. So that's why you want those rest days. It's really, don't think of it as rest days, that's your building days. Like the tissue is actually forming at that time. Isometrics, I found this on X under a physical therapy site. Isometrics are a good way to go if you're not ready to lift weights. And you'd really just have to hold them for about 30 seconds. So what's an isometric? That would be like a wall sit. So like you're sitting against the wall, squatted, you're not really lifting a weight, you're not really going up or down, you're just holding it steady, but your muscles are contracting, fighting gravity. That's an isometric. So isometric means same length. So the muscle doesn't change length. So like doing this and holding it, that is an isometric. If I do this, my muscles are changing length. So isometrics is another good way to start, and just hold it for 30 seconds, rest a little bit, hold it for 30 seconds, etc. More than 30 seconds doesn't really do anything. So osteosarcopenia is also associated with what we call inflammaging. What is that? The chronic inflammation that seems to happen in humans in a modern society over time. So you get more chronic low-grade inflammation, which induces more oxidative stress, which induces more inflammation. You get all of these cytokines, those pro-inflammatory little proteins that are meant to just fight off a quick infection or clean up a quick injury. But in modern society, we just live with these low levels of these things all the time. Tumor necrosis factor alpha, interleukin 6. Well, when you have these low levels of chronic inflammation all the time, you're turning off the osteoblasts and you're turning on the osteoclasts, and you get more bone resorption. So inflammation, chronic inflammation, terrible for your bone. And then of course your hormonal relationships we talked about. This is not a hormone talk, that probably deserves its own talk, but lower growth hormone levels, lower T, lower estrogen, all lead to poor quality bone and muscle.
Speaking, is plantar fasciitis in women linked in any way to menopause?
I think we just got a question, is plantar fasciitis related to menopause? I would say a lot of connective tissue pain, aches and pains, joint pain, muscle pain, etc., do happen when we lose our normal levels of estrogen, because there's estrogen receptors everywhere, and estrogen is protective of pain and protective of connective tissue, protective of bone, protective of the heart. Estrogen is really good for you, and when you lose the estrogen, you begin to have symptoms because the tissue is just not functioning at the same high level it was before that. So inflammation and oxidative stress, we already talked about how these proteins come out and inhibit osteoblasts and stimulate osteoclasts. Well, then you also get more reactive oxygen species, which if you've seen my other talks, those are those free electron molecules, and electrons don't like to be single. They always want to be in a pair, and they're just going to glom on and find an electron wherever it can. And that causes oxidative stress, which is like rust. So you're going to have more rust inside your body. And then that's going to damage bone, particularly connective tissues, long-lived connective tissues like collagen. And then you're going to induce more inflammation, and again, a self-feeding cycle. So estrogen deficiency adds to all of this, because estrogen also helps to manage the redox homeostasis. What do I mean? When you create energy in the mitochondria and you produce the side effect of reactive oxygen species from the redox pathway of energy creation of making ATP with the electron transport chain, estrogen kind of helps to modify that and make it stable and balanced. And when you lose these regulatory molecules, you start to make more reactive oxygen species. Another reason to take extra antioxidants, especially as we hit middle age and older. And then of course, mitochondrial dysfunction, we sort of just talked about, and senescence. That's when cells become dead, like let's say an osteocyte in a bone just dies. Well, normally it would get debrided, cleaned up, recycled, and a new one would be put in its place. But sometimes they just sit there and send out damage-associated molecular signal patterns, which increase inflammation, which increases osteoclasts, which makes your bone worse. So we want to avoid inflammation and oxidative stress. You want to take antioxidants and avoid anything that increases free radicals. So this is a beautiful picture of an osteoclast coming on and chewing up bone. Cytokines, inflammatory proteins, stimulate osteoclasts, inhibit osteoblasts, increase ROS, reactive oxygen species. Those, the reactive oxygen species, kill the osteoblasts, stimulate more osteoclasts, and induce more inflammation. And then an estrogen deficiency just exacerbates all of this. So yes, any connective tissue with collagen can have problems with estrogen deficiency or menopause. So micronutrient subclinical deficiencies. This is a problem we don't really talk about because, of course, in healthcare, a lot of doctors are mandated to just follow the RDAs and the normals and the government set levels, but nobody ever talks about subclinical deficiencies and optimal levels of anything. So a subclinical deficiency is a deficiency of a certain micronutrient, hormone, whatever, that isn't at a bad enough level to be obvious, or you're still in the normal range on the little lab report you get. So calcium, you can have a subclinical deficiency of calcium. If you do, your body is going to take calcium from bone to put it to use in other functions. Calcium is one of the number one ways our cells and our nerve cells communicate with each other. And so appropriate levels are always going to be maintained by your body to protect the brain. So if your body has a subclinical deficiency, it's going to pull it from somewhere. What's the number one place to store calcium? Bone. So it's going to pull it out of bone and make your bones subtly weaker. Vitamin D, same thing. If you have a subclinical vitamin D deficiency, you're unable to absorb, produce, and use calcium in an efficient manner. And I cannot tell you how many patients have subclinical vitamin D deficiency in this country. Huge amounts. Vitamin K, we already talked about how that plays into bone health when we talked about warfarin. But vitamin K deficiency will reduce your production of normal osteocalcin, which is an important hormone that allows bone to remodel appropriately. And osteocalcin has crosstalk with the brain. We're going to talk about that briefly. Magnesium, subclinical deficiency. 60% of Americans are deficient in magnesium. Huge regulator of bone health, cofactor in hundreds of chemical reactions, especially in bone, and interferes with parathyroid and vitamin D metabolism. And it is a cofactor for the activation of vitamin D into the active form of calcitriol, cholecalcitriol. So all of these, you really want to just maintain optimal levels at all times for a variety of reasons, one of which is good bone health. Calcium, D, K, magnesium, your basics. So osteoporosis, we now know with recent work, has a correlation and something causal relationship with cognitive decline or dementia. So people with osteoporosis are at an increased risk for dementia. People with dementia are at an increased risk of hip fracture, a threefold increased risk of hip fracture if you have dementia. Maybe because it's easier to fall, probably because there's weaker bone and sarcopenia associated. End stage dementia, and you get a hip fracture, over half will die within 6 months of that hip fracture. And the ones that survive will get even more cognitively impaired. If you don't have dementia and you get a hip fracture, only 12% die in that 6-month time frame. So you're probably thinking to yourself, wait, people die from hip fractures? Yes. That is one of the fundamental number one problems in this country is the number of hip fractures people have and the mortality rates after them. It's extremely high and I don't want to say 100% preventable, very preventable with good bone health. So the bone and brain, vitamin D and serotonin, tightly linked. Vitamin D, crucial for calcium absorption and utilization and bone mineralization. Also important for serotonin levels and osteocalcin levels in the brain. D deficiency, vitamin D deficiency has been linked not just to bad bone health, but to neurocognitive decline, dementia, depression, Alzheimer's. Strongly correlated. Osteocalcin is sort of the link between bone and brain. This is an osteokine or hormone or a protein released by the osteoblasts, the bone-forming cells, and it helps proper mineralization of bone. So it allows the calcium and the hydroxyapatite to actually bind into the matrix. Insulin will signal osteoblasts and help to get the form of osteocalcin that's useful to your body, so decarboxylated, and then also will affect the muscle function and the muscle load. So insulin, and this isn't a talk on insulin resistance, but if you have insulin resistance, it really affects how the body responds to sugar in the serum. Muscle being the primary place that sugar is stored is glycogen. Calcium, the primary place it's stored is in bone. Well, if you have poor insulin signaling, your body doesn't really know what to do with all this sugar. It doesn't know how to store it properly, and the muscles don't work right. You get sarcopenic, or worse, obesity with sarcopenia. And then the osteoblasts are not signaled properly. So there's a direct link between insulin and osteoblasts as well. Insulin is a anabolic hormone. So insulin is used for growing things and making things stronger and better. It's a very useful hormone. You just don't want too much of it, and you don't want to become resistant to it. But insulin will signal the osteoblasts and help the osteocalcin work between bone, muscle, brain. And then osteocalcin has been shown to increase levels of brain-derived neurotrophic factor. So BDNF, that is the substance in the brain that allows neuroplastic connections to form and helps neurons regenerate and heal themselves. So osteocalcin levels are associated with the ability of the hippocampus to form memories and helps your brain function better, we think mostly because of BDNF. And you don't get osteocalcin unless you're mechanically loading bone and stimulating the osteoblasts, which then spit it out. And you can't be insulin resistant.
Jennifer is pumped. She said, amazing information. Thank you.
Oh, thank you, Jennifer. Jennifer likes this information. It is fascinating. Like I said, I'm just touching on it, but it's food for thought. And like I said, anything anybody wants us to go deeper into, just let me know and I'll do that.
Can you tell Christina you're going to get to her question?
Christina, we will get to your question.
It's kind of off topic.
Okay, so the central nervous system, through the nerves that leave the brain and go to the bone, but also through things like osteocalcin and different hormones, regulates bone metabolism. And what's important here? Sleep. So anybody that's watched any of my discussions about health know I'm a huge fan of good, healthy sleep and a strong circadian rhythm. A disrupted sleep, or if you have disrupted sleep, will mess with your bone's cell clocks. So what do I mean? Every cell in the body, not every cell, almost every cell in the body has a clock gene or a series of clock genes. These are genes that oscillate, meaning they turn on with daylight or they turn off with daylight. They turn on with nighttime or they turn off with nighttime. And this is all heavily regulated by the central nervous system by virtue of UV rays that come through the optic chiasm into the suprachiasmatic nucleus, which is the master clock in the body. And then the gut has a clock, but every cell has a clock, and they're all linked together. And your circadian rhythm is hugely important to the ability of your body to self-repair. This is your downtime. This is when the car's in the shop. This is when a plant's in a turnover. This is when the maintenance crew comes in. It always happens at night. So most of your bone repair, growth, recycling, improvement is going to happen at night. And if you're not getting regular sleep and your circadian rhythm is not strong, all of the clock genes in your bone are going to be messed up, and you're going to have dysfunctional relationships between the osteoclasts and the osteoblasts in terms of bone formation and healing. Chronic inflammation, along with a lack of good sleep or an irregular sleep schedule, will enhance the dysfunction of the osteoblast-osteoclast balance, and you'll get osteoporotic bone or osteopenic bone. And again, lower bone mass shown to be highly correlated with worse performance on cognitive testing. So is poor sleep. So all of this is linked. In the human body, almost everything, every disease process you bring up, there's going to be fundamental things you can do to make it better that are universal truths. Good sleep, good diet, less inflammation, less oxidative stress, less mental stress. All of this is true and works for almost every system in the body to improve it, including bone. So if you want your bone to be able to heal itself, get bigger, lay down matrix, lay down mineralization, you have to have regular sleep. So how do we manage bone health in medicine? I'm just going to quickly go through a couple traditional practices of medicine, and I'm only going to bring them up because I find it interesting that almost every culture, traditional medicinal practice have the same fundamental truths again. Most all of them recommend good sleep, good diet, movement or exercise, less stress, social interactions, and things like that, like good micronutrients. And we're going to talk about a couple of them. So some traditional practices we're going to talk about, of course, the pharmaceuticals, because we are in America and that's what we do. I'm going to tell you the drugs that you're going to get prescribed, and then some more modern natural approaches in the way like I like to approach bone health. Oops. So Ayurvedic medicine, so this comes from India. And forgive my pronunciation. The Asti Dhatu is the bones and teeth in Ayurvedic, and that is considered to be the body's structure and ability to move. Makes sense. That's what we just talked about. Ayurvedic medicine tries to balance what is known as Vata, Pitta, and Kapha doshas, or these are the body constituents, and it focuses on the root causes of poor health or the root causes of poor bone health. What you eat and how you live. Diet, lifestyle. Sound familiar? So this is a very well-known, well-studied method of medicine that has thousands of years of history, and they support a good diet, good sleep, and have a good lifestyle, and you're probably going to have better bone. So we really can't argue with that. So in this particular tradition of medicine, they have sort of a focus on detoxification or clearing toxins out of the body to allow the body to renew. Think of this as like external forced autophagy. So your body has a system inside to detoxify and renew all the time. It's ongoing, but some medicinal traditions and some cultures like to add this extra external detoxification to sort of make it happen faster, I suppose, to like clear out the debris and bring in the new healthy micronutrients to allow rebuilding. Ayurvedic medicine is big on massage, and I think this is probably because the stimulation or the mechanical pressure on certain muscles and ligaments and stuff probably helps stimulate healing in a certain way. They do a lot of detoxifying enemas, turns out. And then they have herbal steam bathing, which is also kind of common to a lot of other healing traditions. So in Russia, you've got the banyas, and you've got the Finnish saunas in, Scandinavia. So herbal steam to promote sweat eliminates toxins as well. Another way to detoxify. Sweat really is a great way to detoxify. You get rid of a lot of bad stuff by sweating. And then a lot of poultices they use. So these are topical applications of herbal remedies. No different than in America, we topically apply chemicals with our pharmaceuticals. In most of these other traditions, you're going to topically apply natural things like CBD and stuff like that, or menthol, peppermint, whatever, and it's going to provide certain healing remedies. So Ayurvedic medicine does have particular things they use for bone health. Meat and I don't know how to say it, Jawara rice are suggested for bone and muscle well-being. Meat, we already know why. It's the collagen, it's the amino acids, period, end of day. You need the amino acids, the glycine, the proline, the hydroxyproline, to form the triple helix, and then you need the protein for the osteocalcin, the osteoblasts, the osteocytes, and all the other proteins that play into bone health. So you got to get protein somehow. So yes, meat, and then this rice, I would assume, is probably heavy in minerals. So ashwagandha, a big molecule in Ayurvedic bone health, reduces pain and inflammation, promotes bone calcification, it's thought, better bone healing, and increases the number of cells in bone tissue or osteocytes, which means there's going to be more osteoblasts, right? Because osteocytes come from osteoblasts. Ashwagandha is considered vital for strong bone health. Shatavari, known for bone strengthening properties. Gugula is another mix, anti-inflammatory properties, thought to reduce joint pain. And of course, one of our favorites, turmeric. We do have ashwagandha in some of our gummies and in our focus series and our energy series, which are heavy on the adaptogenic molecules. But I'm a big fan of turmeric. Curcumin, the active ingredient in turmeric, which is of course curry, helps lower bone density, or helps with low density. It doesn't lower bone density. It helps improve lower bone density due to its anti-inflammatory properties. So it reduces that chronic low-grade inflammation that we're always constantly trying to fight, which reduces osteoclastic activity, which helps your bone mass. Ginger, another one, anti-inflammatory again. In our joint health multi, I put turmeric with ginger because they've both been studied often in terms of joint health, musculoskeletal pain, but it too is anti-inflammatory, and it also helps the digestion. So theoretically it could help you maybe absorb some more micronutrients. And then there's just other different combinations of herbs that are common in this tradition. But fundamentally, all these are doing is giving you the right micronutrients, reducing inflammation, reducing oxidative stress, which we've been preaching since we started with the well theory. That is the fundamental way to stay healthy and have optimal health. You know, which type of package you pick to do it, that can vary, but fundamentally you need anti-inflammatory, antioxidant molecules, you need micronutrients, you need a good diet, good sleep, and you need to move and lift things. Ayurveda says the same thing. The Ayurvedic lifestyle, this is cut from a website of some medical hospital in the States that is starting an Ayurveda center. It's starting to become more and more common. Daily practice thought to be beneficial. Regular physical exercise, gentle yoga to improve posture and strength, spine supporting muscles. Early morning sun exposure, get the cortisol going in the morning. Maintain good posture. I preach this all day long. Good posture all day long makes you have less pain in general. They suggest 5 grams of sesame seeds daily with palm sugar. Not sure I can get behind that one. Prepare bone broth with warming spices like ginger and pepper. Bone broth, we already talked about that. Maintain regular bowel movements. All that means to me is that you've got a good gut biome and good digestive health. Keep a stable, healthy body weight. You don't want to be too big. You don't want to be too little. You want to be in Goldilocks, perfect in between. So sunlight, walks, active routine, keep a routine, good circadian rhythm. Allow for sufficient rest and sleep. Try to avoid stress and anxiety. Mental stress upregulates cortisol when it's not supposed to be upregulated, which increases inflammation, reactive oxygen species. Meditation and deep breathing, that helps with mental stress. And then of course, avoid smoking and minimize alcohol intake. So avoid excessive alcohol, don't smoke. Sound familiar? So quickly, traditional Chinese medicine and bone health. Chinese medicine follows the qi or energy flow of the body. And again, it's been around for thousands of years and has had great successes. So you really can't argue with that. They have different groups of herbal connections that they put together that are all thought to help bone health. So icarine, I'm never going to be able to pronounce these. These are the different herbs they like to put into formulations to improve bone health. But again, what it's doing is providing antioxidant materials to protect the osteoblast, reducing chronic inflammation, providing minerals and cofactors to allow for the extracellular matrix to be mineralized with a hydroxyapatite. So again, all the same fundamental things between all of our different traditions, just applied slightly different ways. I put this other thing here to show you the T-score. Some of you out there might be wondering about the bone density scan. That is just our most covered and most common method of assessing your bone density. All it's looking at, if you remember in high school math, the normal distribution, so a bell curve, right? Most things are in the middle. You have some outliers to the right, some outliers to the left. And right from the middle, there are certain spaces to the positive and negative side that are called standard deviations. And your T-score is just looking at the standard deviation of your bone relative to what's considered to be normal bone in we'll say a 30-year-old or your age. So you can look at it versus your age group or versus your best bone mass. So what you don't want is a negative 2.5. So you don't want to be 2.5 standard deviations on the downside from a normal level of bone. That is technically osteoporosis. That's all the DEXA scan's doing. So it's kind of a crude way to look at it, but it's really all we have and all that the insurance companies will pay for anyway. So it's our best method to assess your bone density. So again, different formulations here. Erxian decoction, Lu Wei Di Huang, all of these increasing density, reducing oxidative stress, reducing inflammation. And then interestingly, the Bushin Zhuanggu granule is thought to regulate gut-derived 5-HT, which plays into serotonin, which plays into brain health, which plays into bone health. So it's interesting how we're now learning how all of these ancient traditions really have strong molecular basis in how they work. I put this picture because this was fascinating to me, using traditional Chinese methods to improve fracture healing, probably increasing blood flow and stimulating neural input. But basically, by putting these acupuncture and other little devices on, you can increase the blood flow and improve fracture healing. This was just somebody with a toe fracture. I just thought that was interesting. So traditional Chinese medicine focused on reducing oxidative stress, reducing inflammation, increasing micronutrient intake. Acupuncture, which stimulates the energy flows of the body. Okay, that's the basis of that. Diet therapy, again, very familiar. Exercise, Qigong and Tai Chi. Now, these are important for a reason that is not in this talk, but probably I would like to get into at some point. Preventing a fall is your best way to not get a hip fracture. Better than taking a drug to make the bone stronger, okay? You will have 0 hip fractures if you don't fall and break your hip, right? Doesn't matter what your bone quality is. So anything that improves your ability to balance is going to be a really good medicine. Qigong and Tai Chi have been studied for this and have had great success in improving balance and reducing falls, which of course dramatically drops the rate of hip fractures. And also they improve posture, which will dramatically drop the rate of vertebral compression fractures. Yoga should probably be in this list too, but yoga is more in Ayurveda. Traditional Chinese is going to be Qigong and Tai Chi. So if you have the opportunity to get involved in any of those 3, I would do it because balance is your best way to prevent a hip fracture. Now, if you can have good bone and good balance, that is game changing, right? So if you do have osteoporosis and you have to take a medicine, do that, but I would add something to improve balance too. All right, so let's talk about the meds, the drugs that people like me, unfortunately, that's usually what insurance is going to cover. You think insurance in my state or anywhere is going to cover a Qigong class or Tai Chi? No, but they'll cover a bisphosphonate. So the mainstay treatment, the first generation bone drugs are the bisphosphonates. This is your Fosamax, your Actonel, your Reclast, okay? They inhibit osteoclasts. So they stop the osteoclast from having the ability to chew up too much bone. And by doing that, it slows the normal bone loss that you get with time, with aging, with microfracture, with lack of estrogen. So you either take these orally every week or every month, or some are IV, like Reclast is once a year. They are thought to reduce fracture risk somewhere between 40 and 70%. Now that's a huge range, so to me that's somewhat meaningless. But at the end of the day, they do reduce fracture risk when you fall and do something that would normally crack your osteoporotic brittle bone. If you take these drugs, you're gonna have better bone and less likely will that fall cause a fracture. There are side effects, and these are well known. GI irritation, so Fosamax, I think you have to take it sitting up. You can't eat for hours afterwards. There's a lot of GERD associated, big problems with that. Rarely jaw osteonecrosis, common problem with almost all of the osteoporosis drugs. And then fracture, what's called atypical femoral fracture, proximal femur fracture, will happen with long-term use. It's paradoxical, I know, it doesn't make sense. You take a drug to help your bone, and then you weaken high stress levels of bone over time and can get fractures. So this is seen with long-term use. It's still rare. So less than 5 years of taking Fosamax, your risk is about 2.5 people per 10,000 people. At 8 years of taking Fosamax, it jumps to 13 people per 10,000 people. So again, 13 per 10,000, that's really rare. But because the risk jumps so dramatically between 5 and 8 years, what we now sort of mostly recommend is what are called drug holidays. So anybody that's been on Fosamax, Actonel, Reclast, whatever, for 3 to 5 years, we usually recommend take a drug holiday for a year or two and then get back on something. Also, what you don't know or what you should know with all of these drugs, every FDA approval comes with the caveat that you also are supposed to be taking D3 and calcium. So you still have to supplement even on these drugs. Denosumab or Prolia, this is your every 6 months subcutaneous injection. This is a monoclonal antibody, and it inhibits rank L. Rank L turns on osteoclast. So it's another way to slow down the function of the osteoclast. It blocks rank L with an antibody, a synthetic antibody, and that effectively helps to preserve your bone density. It's usually only covered if you've failed the drugs we just talked about, like if you have really bad GI side effects, or I guess if you've got hints of jaw osteonecrosis, but of course it's a risk factor with all of them. You're only going to get Prolia covered if you fail the other ones. Again, it's going to block the protein that turns on the osteoclast, and it reduces vertebral fracture risk by close to 70%. A risk of hypocalcemia, which of course will mess up how your brain talks to the body, and a rebound bone loss if you stop it too quickly. So again, the pharmaceuticals seem to always have warnings, side effects, and problems, right? But they do increase bone density and reduce fracture risk. So I don't want to discount them. I have prescribed them. I will continue to prescribe them for people that need them. But ideally, you would be in a boat where you would never need these. So the anabolic agents, anabolism, anabolic things build. So insulin's anabolic, testosterone's anabolic, parathyroid hormone analogs are anabolic. These are injected daily. This is your Forteo and your Tymlos. They stimulate osteoblasts. So remember, everything else we've talked about is slowing down the osteoclast. Here we have something that's on the build side. So it's going to stimulate the osteoblasts and increase the formation. And all you're doing is changing that balance. Normally you want to be perfectly balanced, right? After you grow and you've formed your full height, you want to take away a bad bone and replace it with the same amount of good bone, if not more, with exercise. What happens with osteoporosis is a balance is skewed to the negative side. So some drugs try to stop the osteoclast so that this can catch up. Some drugs increase this so it catches up to the increased osteoclast that happened with osteoporosis. This is one of the ones that increases osteoblast or bone formation to fight back against the osteoclast. But again, it's not very accretive. It's slightly accretive, but the best way to add bone mass back is exercise. This is used for very severe cases. Again, what that means to me is not often covered by insurance, and will cut your fracture risk by, again, 50 to 65%. There used to be a hard stop at 2 years because of a theoretical risk of bone cancer or osteosarcoma, kind of a bad side effect, I would say. Very rare. That black box warning has since been removed when the post-market data was analyzed more closely. But a lot of doctors still cut you off at 2 years, but you technically don't really have to anymore. But again, all of these drugs, they work, and they work in very mechanistic ways that have been proven, and the FDA has said they're fine, but they all have side effects that none of us want. Avinity, this is another new one, or romosozumab. Notice how all of the really expensive biologic drugs end with MAB. To me, that means your insurance isn't going to cover it if I see that. This is a newer monoclonal antibody, monthly injection for 12 months. It boosts bone formation and reduces resorption. So this is one of your first dual effects. Remember, everything we've talked about either stop the osteoclast or increase the osteoblast. This one is supposed to do both. Reduces your vertebral fracture risk by 73% in the clinical trials that allowed it to gain approval. Black box warning. What is a black box warning? This is a warning the FDA puts on a drug that they're still going to approve, that there's a side effect that's so terrible it deserves a black box. This has a black box warning for cardiovascular, so risk of stroke, risk of heart attack, risk of hypertensive episodes, and also the same old risks of all of these drugs, atypical femoral fracture, osteonecrosis. So not without side effects. So if you have a cardiovascular history and you're on this, maybe just go check with your cardiologist to make sure it's okay. But those are the pharmaceuticals that we generally prescribe in common practice. Selective estrogen receptor modulators, or SERMs. So this is your raloxifene, your Avista. It's an oral pill, you take it every day. What this is doing is it's gonna selectively block certain estrogen receptors, okay? So it's gonna mimic estrogen's bone protective effects without some of the other risks of hormone replacement therapy. Okay, so it reduces vertebral fracture risk by 30 to 50%, but it's not gonna give you hot flashes, theoretically. No hip fracture benefit. I have no idea why. But this is the way pharmaceuticals work when they get approved. So in that clinical study, they showed vertebral fracture risk reduced, but people got the same amount of hip fractures. Well, hip fractures increase morbidity or death, so I don't want a hip fracture. So I think this is an option. It's not often prescribed, but it is an option. Sorry, it does increase I misspoke earlier. It does increase hot flashes. So it's gonna turn off certain, not turn off, but it won't turn on certain estrogen receptors. It'll selectively turn on other estrogen receptors, and they've made them so that it targets the estrogen receptors on bone. But you do have some of the side effects of taking too much estrogen later in life. So this is an option, and it's used periodically, very patient specific. And then calcitonin, this is kind of an old school one. It's usually a nasal spray. They get it from salmon, or used to before it became synthetically developed. It inhibits osteoclast. So calcitonin is made in the thyroid, parathyroid system like we talked about, and it inhibits osteoclastic activity with modest increase of osteoblastic. So this is a natural hormone we have that's going to have dual action. Most people use it for pain relief post-fracture. It's not as effective as all those other drugs for fracture prevention like we talked about. I have sometimes given calcitonin to my diabetic patients with Charcot neuroarthropathy, where the bone fragments and just falls apart on its own in an attempt to stop that osteoclastic activity. But there are newer, better ways to do that. So calcitonin is kind of an older fashioned medicine, but it does work. It just doesn't seem to work as well as the more expensive pharmaceutical grade drugs. So there are newer therapies, cathepsin K inhibitors, again, odenacatib. They started studying this and stopped it due to heavy stroke risk. So there seems to be an interplay with some of these drugs in the cardiovascular system, probably through vitamin K if I had to guess. Because remember, osteocalcin will help the bone mineralization in the bone be healthy and strong and appropriate. And at the same time, it will diminish calcification of atherosclerotic plaques. So vitamin K has two benefits for you if you take it, which I do. And if you're messing with vitamin K, you potentially could increase the risk of the calcification of plaquing, which I think would probably lead to heart issues. That may be one way it plays into it. A key role in degrading the organic matrix, particularly type 1 collagen. So cathepsin K inhibitor, again, a double negative. If you're inhibiting an inhibitor, you're allowing the function that it normally inhibits to happen. So this inhibitor degrades bone matrix. You don't want that, so you inhibit it. Unfortunately, it causes a lot of strokes. A newer antibiotic agent. They're also now coming out with anti-sclerostin antibodies. Remember we talked about the importance of sclerostin? I put this to show you. This is a recipe I found, which is very, very good for bone health. It's 2 cups of bone broth with 8 ounces of ground beef. I'm going to assume it's grass-fed, grass-finished, and 3 eggs. I'm going to assume organic, cage-free in somebody's family farm. High vitamin A, vitamin D, B12. You need to take B with your D to have good bone health because B is integral to the way the genetic process works for protein formation. So high in D, high in B, high in iron, zinc, selenium, choline, phosphorus, and potassium. And then, of course, collagen. So just something to think about. I put this here with these drugs that have these major side effects and are extremely expensive, may or may not have coverage, when really prevention is the best way to manage this. And just simple dietary changes can go a long way. Okay, estrogen, we sort of talked about this, probably deserves its own talk. A lot of people are still concerned about breast cancer risk. The actual increase in that study from the Women's Health Initiative that got everybody to freak out was 8 out of 10,000 people. But that was only seen when estrogen was mixed with medroxyprogesterone at a certain level. And the estrogen-only arm actually had less risk of breast cancer. So they've done other analysis of the data from that study and looked at it different ways and done new studies since then. And the breast cancer risk is not as big as people were led to believe by the press or the media at the time that it came out. So taking hormone replacement therapy is beneficial for a variety of reasons. You're obviously going to want to talk to your OBGYN about this, but it will preserve your bone mass for a longer time period. It mimics the normal levels before menopause, and it's bone protective. Thyroid hormones, we talked about it, indispensable for normal bone metabolism. Strong regulator of bone turnover, so it's crucial for that day-to-day repair and rebuilding. So your T3 and your T4 levels are going to interplay with your clock genes, regulated by your circadian rhythm, to help balance the day-to-day repair system. T3 directly stimulates the resorption or the cleanup of bad bone. It actually binds receptors in the osteocyte, the bone cell. And if you have too little of it, it shortens your bone remodeling cycle. If you have too much of it, you're going to resorb too much. So remember I told you hyperthyroidism leads to osteoporosis. It's because T3 is directly stimulating bone resorption. So you have accelerated bone turnover, which decreases your bone mineral density and your bone mass. So again, everything in nature has to be perfectly balanced. Loves a balance, loves entropy, wants everything to be evenly distributed with the least amount of energy used. So you can't have too little or too much of your thyroid, you can't have too little or too much of your D, you can't have too little or too much calcium, et cetera, et cetera. Subclinical hyperthyroidism, I think we probably see a lot, and it probably sees us more than we think it's out there. In other words, it's probably underdiagnosed. Low or normal TSH levels, which remember that's all most doctors are going to check is your thyroid stimulating hormone level, but normal free T levels. So you have slightly low TSH, normal free T. This can negatively impact your bone density and decrease the mineralization, and you can have an increased fracture risk. So these are things to just sort of think about whenever you're going to get your yearly checkup. Maybe ask for a full thyroid panel. The other thing about TSH is next time, just for fun, look at the range of normal. It's massive. It's like from 1 to 3.5 or whatever. So what really is optimal? Again, it's going to come down to you individually, and your doctor is going to have to work with you on that. Hypothyroidism will actually lead to decreased bone turnover. So hyper, you're turning over bone too often. Hypo, you're not turning over enough. Reduced osteoclastic activity, but also reduced osteoblastic activity. So it's not great bone, and you're basically keeping bad bone longer. So hypothyroidism has a whole other bunch of problems, right? You get cold intolerance, you gain weight, your hair is thinning, it's falling out, you feel like crap, you hurt, you're irritable, you're fatigued, the whole bit. So nobody wants to have hypothyroidism, so we all get it treated. Problem being, if you take too much thyroid replacement or levothyroxine or Synthroid, you can damage your bone. You can cause increased bone turnover. So people that are treated with too much levothyroxine or too high a level will get osteoporosis. You got to be perfectly managed with the thyroid, and that is so hard to do. So you don't want subclinical hypo, subclinical hyper, and you don't want overtreatment, and you don't want undertreatment. So if you have any of these conditions, you just need to get a doctor that is really going to do a deep dive and help you with this. So the parathyroid, we talked about it. That's a micrograph of the parathyroid gland sitting next to thyroid tissue. It's 4 little glands behind the thyroid, so closer to the spine, right? It's thyroid, parathyroid, throat. They regulate your serum calcium levels. There's 4 of them, and they're going to stimulate the release of calcium out of bone. So this is when your body says, hey, I need calcium because I don't have enough in the brain for the neurons to talk to each other. Parathyroid's going to say, I can help out, and it's going to stimulate the release of calcium from bone to get into the system. It'll also enhance the absorption of calcium from food, so it makes your intestine a little bit more efficient at pulling calcium in, and it will promote the production of that promolecule vitamin D in the kidneys so that it can become active vitamin D3. And it's going to reduce the excretion of calcium in urine. So parathyroid is a really important regulator of serum calcium levels. And the overall effect is to increase your levels of calcium. So hyperparathyroidism is seen when you have low vitamin D because it's trying to promote production of vitamin D, and it's trying to pull calcium out because it's not being used properly because there's not enough vitamin D. Calcitonin will decrease serum calcium levels and is produced by the thyroid, and it's produced when the serum calcium levels are too high. So if your body's pulling too much calcium out of the bone, the body's going to sense that, and the thyroid's going to spit out calcitonin to counteract that. And all of this is a very tightly regulated dance, very finely orchestrated. So what are your natural ways? Well, we talked about Ayurvedic, traditional Chinese medicine. Now we're going to talk about my way of naturally treating things. Number 1, Mediterranean diet. If you eat a solid Mediterranean diet and it's all healthy and organic, you're going to get a lot of the micronutrients you need, a lot of the proteins you need. and a lot of the antioxidants and anti-inflammatory molecules you need. Now, a perfect Mediterranean diet is going to be really hard to achieve, particularly if you work or have to take care of a family. You're supposed to get 8 to 9 servings of different fruits and vegetables every day. Only extra virgin, cold pressed olive oil, organic, whole grain breads, which means it's whole grain. That's so hard to find in our country. You can find it, but it's hard to find, and usually it's a dense bread that nobody in your family is going to want to eat. You almost have to acquire the taste for it. But a perfect Mediterranean diet is your best way, of course. We're always going to say diet first and exercise. But because I know I don't get a perfect Mediterranean diet as hard as I try, I'm going to supplement. So I take D3, I take my B vitamins, so that works better. I take magnesium, calcium C, omega-3, vitamin K, also ashwagandha, like we talked about, and some of the other more herbal and traditional methods of supplementing to help bone health. Turns out these all help other things in your system too. Again, because they can have universal effects because they're fundamentally making the mitochondria healthier. You're producing less reactive oxygen species and you have less inflammation. So that's why these supplements and healthy things can have universal effects, which is one of the reasons most medical doctors poo-poo things, because they think, how is it possible that one thing can make everything better? Well, that's why, because you're basically fixing the foundation. So D3B, magnesium, calcium C, omega-3, vitamin K, along with a healthy diet and lifting some weights. So if I were going to write a prescription for you for good bone health, it would say get sleep. It really should say get regular sleep. It would say eat well, really should say Mediterranean diet. And it would say take supplements, these are the ones, and I would say lift weights, and I would probably give you a way to do it, or I would more likely send you to physical therapy and let them start with you, and then let you graduate to a program you could do at home or with a personal trainer. So we have our vitamin K in olive oil, which is naturally anti-inflammatory. Vitamin K supports cardiovascular health. Remember, it doesn't allow those plaques to get mineralized, and then it helps your bones mineralize properly. The B vitamins are important for nerve function and bone health and makes D3 work better. The Mindset gummy I like because it has B12, magnesium, and D3. So not only is it good for your mindset, your mood, and your brain, and your nerve function, but all three of those are used in bone health too. And then omega-3, very naturally anti-inflammatory. We didn't really get into that, but omega-3 is so hugely anti-inflammatory, it really helps with that core fundamental problem that is going to stimulate the osteoclast. So it's going to help regulate that bone turnover. The connective tissue multi is one of my first supplements, and the reason I sort of got into this quest, because it has everything that helps people heal better from orthopedic surgery and surgery in general. So it's got your calcium, your C, your zinc, your magnesium. So these are the supplements I would recommend for bone health. But number one, find someone that can guide you so you're safe, obviously. You don't need to go deadlifting 300 pounds if you've never done it before. But you probably should incorporate weightlifting and fighting gravity into your daily routine. Progressive overload. You need to have days between to build the bone and build the muscle. You need to have the right building blocks to build the bone and build the muscle, or the micronutrients and supplements. You need a decent diet, and really you've got to have a very good circadian rhythm. You can't deviate. That is so important for your body to repair the bone at night. So hopefully that gave you, like I said, we touched on multiple facets of bone health. I did write a book, Bone on Bone, that gets into a lot of this and sort of goes into the way to incorporate all of this into your life in I don't want to say an easy way, but a stepwise manner that makes it much more approachable. So sleep, diet, exercise, mindset, all of it is important and achievable, and they all work well together and make each other stronger, but you got to start somewhere. So Bone on Bone, I kind of explain why all of this works, give a lot of evidence and references, and give you sort of guidance on how to become healthier and ideally prevent the need for those drugs that have such terrible side effects. But I'm here to tell you, if you need those drugs, take them, because you do not want a hip fracture.
I have one question right now.
Or we have a question,
It's not related to this.
and it's not related to this. Okay.
How do you take care of your feet from walking a lot? Her big toe nails always get damaged from hitting the shoe, and my soles begin aching too much usage.
This is a question about foot pain. So this is somebody that has foot pain with too much use, and the toenails I guess, get bruised from banging the shoe. Well, nail hygiene matters. You've got to trim your nails flat across, flush with the end of the toe. They can't be longer than the toe. That's the first way to keep it from hitting the shoe. Most people that run recommend getting about a half size bigger to allow a little bit of normal foot movement and foot swelling when you're exercising. Your day-to-day shoe, you don't necessarily have to do that. Shoes that incorporate a rocker bottom, like the Healing Sole, which is a shoe that I invented, can take stress and strain off of the foot. But it sounds like maybe there's some soft tissue tolerance issues with these particular feet, because too much use implies that it's not able to withstand progressive overload, which means the feet probably need to get stronger. I'll send people to physical therapy for foot core strengthening, stretching the heel cord, which takes a lot of stress off of the foot, making sure that the nerves aren't being compressed. So we can do techniques like dry needling and cupping, different big movement nerve glides, and then of course strengthening the core, which includes the hips. If you have strong hips that work well, it takes load off of the feet, believe it or not, when you're ambulating and standing. So there's a variety of ways you can combat that. But first is nail hygiene, the right fitting shoe, and then making sure your foot is able to tolerate load, which means it's got to get stronger.
Debbie, does Pasquale have value in terms of reducing inflammation?
Oh, Debbie is asking if boswellia is beneficial in terms of reducing inflammation. Yes, in fact, it's in my arthritis gummy. Boswellia is frankincense, or from frankincense, strongly antioxidant and anti-inflammatory. Topical or oral, it is very, very helpful. So I'm a big fan of boswellia. Yes, it's in our arthritis gummy, along with bromelain, which is out of the pineapple, also antioxidant, anti-inflammatory. And yeah, my favorite is PEA, palmitoyl ethanolamide. You make it, I make it, we make it all day long. Part of your endocannabinoid system, found in certain foods, but it's a very good anti-inflammatory molecule, particularly for nerve pain. All right, well, that's it. I hope that helped you out and gave you at least some springboards for discovery, and you can delve into each of those topics a little bit more deeply, or talk to your physician about it, or come see me. The book is another way to get into it a little bit more deeply. But bone health and muscle health, can't tell you how important it is. If you want to be that 90-year-old that's playing football with their grandkids, you have to get stronger, and you've got to move, and you've got to eat right and sleep right. There's just no way around it. There is no magic pill. It's going to take work, but it's fun work, and it's work you can do.
Just learned her cholesterol med is reducing the vitamin K. What to do?
Somebody in the audience just learned that her cholesterol med is reducing vitamin K. I would say to supplement with vitamin K. If you're on a cholesterol med, that means your LDL is too high, which means your doctor probably thinks you have a cardiovascular risk. Vitamin K has been shown to reduce cardiovascular risk by virtue of the way it interacts with osteocalcin and the mineralization of plaquing. So vitamin K is a great way to help your bone health and support the cholesterol system in a beneficial way. All right, I think that's it. That's all for great questions, by the way. Hopefully this helps you, and just go enjoy the rest of your Sunday. And thanks for joining us.